Hi, everyone. Welcome. I'm Megan.
I'm Stacy.
And welcome to our Fit for Fellowship, our survival guide for the first year general cardiology fellow. Welcome to session 4. So we're very excited to have you all. For everyone coming back, welcome back. For those who are first timers, welcome. If you've missed any of the prior lectures, they're available on the ACC, California ACC website. So feel free to check those out for sure.
All right. And so you guys kind of probably know the drill. We're going to start off with the lecture. Today we have Dr. Ignacio Velazquez coming from Harbor-UCLA, and I'll give a short introduction very shortly. And during the lecture itself, if you have questions, please feel to chat. Send them in the chat box, either publicly or if you want to send them privately, and we'll be sure to include those in the Q&A session after the lecture. Please keep yourself muted. And so without further ado, let me go ahead and introduce Dr. Velazquez. So he is at Harbor-UCLA Medical Center. He's an assistant professor. And Dr. Velazquez received his medical degree from University of California, Irvine School of Medicine. And he completed his internal medicine residency at Harbor-UCLA Medical Center. He's board certified in internal medicine and in cardiovascular disease. And today he's going to talk to us about syncope. So without further ado, let me go ahead and get us started. Okay. Let us know if there are any audio issues.
Welcome everyone to the Syncope Bootcamp section of this series. My name is Ignacio Velazquez. I'm the Cardiology Clerkship Director at Harbor-UCLA Medical Center with the Cardiology faculty, and I'm Assistant Professor at UCLA School of Medicine. So without further ado, let's jump into it. There's a lot of things that we can and should learn about syncope. It's going to be a very common diagnosis that us as physicians and especially as fellows you'll have to see in the hospital, in your clinic, in different clinical scenarios. And so we're not going to be able to cover everything in this very short kind of overview, but what we'll try to do is talk about a little bit of the more common diagnoses, some of the important diagnoses that we shouldn't miss, and go from there. So first, in terms of definition, syncope we have to define as an abrupt, transient, complete loss of consciousness. It has rapid spontaneous recovery, and the underlying pathophysiology is going to derive from a sudden decrease in or brief cessation of blood flow to the brain. When you see patients with syncope, some of the most important things that you have to remember are the goal is to identify specific underlying causes and mechanisms of syncope, to risk stratify the syncope after you try to figure out what caused it, and then formulating a management strategy, including disposition. So we won't go too deep into all the various etiologies of syncope. Suffice to say, we're going to go over some examples, but I really want to use this slide to illustrate that syncope is a multifaceted disease. It can come from different etiologies with different mechanisms, and they can all be mixed up. Reflex syncope, orthostatic syncope, cardiac syncope all lead to this transient loss of consciousness, and it's going to be up to us to try to figure out what's going on with it. So as you probably already know, careful history taking is the most important part about working up a syncope patient. You want to know what happened before the event, what happened during the event, obviously from collateral information from witnesses or family, and importantly, you want to know what happened immediately after the event. You want to use all the resources at your disposal, including family, like I said, first responders, if you're able to speak with them when they're bringing the patient to the hospital. And in this day and age with technology being so ubiquitous, you can use video or smartwatches, smartphones, things like this to really try to figure out what was happening in a moment of syncope. Physical exam is going to be very important, and I want you to pay special attention to the cardiac exam, obviously, because this is cardiology fellowship after all, but also pulmonary and neurologic systems shouldn't be overlooked by us. It's going to be very rare for a patient that comes in or that you see with syncope cannot have an EKG and ECG. It should be obtained on nearly every patient. It's even non-invasive, low risk, and it can really give you a lot of information. Other diagnostics, however, should be really carefully thought about and ordered only as indicated and needed for a full evaluation of the patient. With just a good history, physical, and EKG, you can diagnose risk stratifying distal. Many of the cases that you'll see in the clinic and emergency room and even in the hospital. Again, we can't go too far into the, we can't get delve too deeply into this, but I just want to show you a very succinct algorithm that was proposed by in the Journal of American Cardiology to try to risk stratify these patients. So when somebody has a transit loss of consciousness, like I said, initially you assess them with their history, your history and physical, ECG, and then just with your history and physical, many diagnoses can be made. Some of the most commonly accepted diagnostic criteria, etiologies, can include reflex syncope, which includes your classic vagal syncopes, your situational syncopes, such as micturition syncope, post-exercise, postprandial, GI stimulation, and your vasovagal ones, which we think of as our classic reflex syncope, which is diagnosed when you have a transient loss of consciousness precipitated by emotional distress or standing, and is usually associated with a typical prodrome of pallor, sweating, nausea, warmth, lightheadedness, dizziness preceding the actual syncopal event. Orthostatic syncope at the same time can be readily diagnosed from a basic history and physical. We'll usually diagnose this as a drop in systolic blood pressure of 20 millimeters of mercury on standing from supine, or a decrease of systolic blood pressure to under, and an increase of, decrease of systolic blood pressure of under 90. If you're hypertensive, 30 millimeters of mercury is going to be your cutoff. So just with these, just in many of the patients that you see that come in with syncope, in taking good history and physical, getting these, this history can really lead to a diagnosis very quickly. Now, if they don't come in with this very clear-cut diagnosis, or if you also have a patient that has high-risk features, such as a cardiac history of ischemia, arrhythmias, valvular disease, sudden cardiac death in their family, having the syncopal episode be associated with either exertion, not post-exertion, but exertion during exertion, or when they're in a supine position, where we usually would expect somebody not to syncopize, coming on suddenly with no prodrome, or once on presentation having hypotension or hypertension. Any EKG abnormalities can obviously be very, can be dubbed high risk in certain clinical scenarios. And then with severe lab abnormalities, you also want to be careful. Other things that we can do for risk stratification that include calculators. So this is just one of them. Now they can be very effective, but you have to make sure that it's suitable to your patient and your hospital, your clinical situation. Sometimes these are used more as part of the culture of the hospital, and sometimes they're not. And importantly, many of these risk scores take care in mentioning that we should be careful using these if there's language barriers. Many times our patients have language barriers, and we have to be very, very sure to have to at least minimize language barriers when we use these types of risk stratification tools. But they can be very effective, and as you see here, if if the full assessment in these calculators come back as negative, they have a very low rate, less than 1% of 30-day serious adverse events. So something that we can use readily. So let's just dive into one of the cases, and we'll talk a little bit more about these risk stratifications. So for case number 1, we have a 73-year-old female with no known past medical history who presents here to present with dizziness. Now, The syncope occurred while driving or when driving. So specifically, the patient reports that she was driving in a car and the car started quote unquote acting funny. She became concerned and fearful of something was going wrong with the car. Shortly thereafter, she felt flush, nauseous, and dizzy. She was able to pull over to the side of the road as she was beginning to feel dizzy. And after she got out of the car, she had triumphant loss of consciousness. She had hit her chin. EMS was called and she presents to the ED. She denies any other episodes such as this. She has no incontinence of bowel or bladder when the EMS found her, and she has no tongue in her, there's no bite marks on her tongue that anybody has been able to elucidate. She thinks that she had no chest pain, she had no palpitations, weakness, vomiting, nausea. She had really no infectious symptoms to speak of, no fevers or chills. And nobody in her family has ever had any problems with their heart, including any sudden cardiac death. Her vital signs were completely normal and stable and within normal limits. And they did take an orthostatic vital signs on her in the emergency department, which were negative. I bet that she's resting comfortably. She's oriented. She does have a small repaired chin laceration. It doesn't appear to be infected. Her cardiac exam is negative for any concerning murmurs, rubs, scallops, and she's clear to auscultation in her lung field. Her abdomen doesn't show any tenderness or rebound, and she has no edema in her legs. And after a full nerve exam, really there's no weakness or any other focal nerve findings. In terms of diagnostics, here's some of her diagnostics. Her chest are mildly elevated white count with no left shift. Hemoglobin may be a little bit low, but that's normal. Electrolytes, nothing too concerning except very, very small troponin leak, probably not too concerning. And this is her EKG. I'll give you all just a couple seconds to look through the EKG, see if there's anything that you can find that's concerning. And I'll say if you guys come with some of the stress and say, other than a little bit of a poor baseline, there doesn't seem to be anything that's terribly concerning with EKG for arrhythmia, bradycardia, ignore block. And so now we have a patient that had transient loss of consciousness that was precipitated by emotional stress. Again, remember, she was very scared when her car started making quote unquote funny sounds. It was associated with prodrome, such as nausea and dizziness. So according to our diagnostic history and physical taking, she had an episode of vasovagal syncope. Now, just to be complete, going over the high-risk features, she has none. She has no cardiac history, no family history. The event wasn't associated with was not associated with lack of prodrome. She was neither exerting herself nor was she in a supine position. And her blood pressure, her vital signs were all normal. Her EKG was relatively normal, without any severe lab abnormality. So in this case, so she does not have a high short-term risk. However, it's important to know that in this patient, she did experience this episode while in a high-risk setting. Remember, she was driving when this happened. Right? She was able to pull over to the side of the road. She didn't get in an accident, but she was driving. So in some cases, even very quote unquote slam dunk vasovagal syncope cases, if it happens during high-risk settings, is reasonable to evaluate a little bit farther. So for this patient, she was placed on telemetry for 24 hours. That showed no significant arrhythmia. She did get an echo showing a normal left ventricular ejection fraction and no significant valve embolization. And cardiac ultrasounds were normal and were free of any significant stenosis. So given this, she was diagnosed with vasovagal syncope. She was given some counter pressure maneuvers. She was told to hydrate, and she was sent on her way. Now, one note on vasovagal syncope is that really the yearly risk of serious injury and death in the vasovagal syncope population is very low, as you can see here. Much less than 1%. However, when it comes to driving, I'm not going to give you any specific recommendations on how long or if not to let people drive after a vasovagal event. But what I will say is that for the 2017 ACC guidelines, they recommend, quote, knowing the driving laws and restrictions of your region and state. So the reason that this is so intentionally vague is because there are, as a matter of fact, lots of different rules regarding driving and syncope in California and different regions of California. So really, you just kind of have to look it up and see how it's practiced, what the community standard is where you practice. So the patient had vasovagal reflex syncope. Like again, she had a prodrome, she had dextrosis, warmth, nausea, and it derives from an automatic activation from an emotional stimulus, which she had. Other forms of reflex syncope include GI activities, micturition, defecation, coughing, sneezing, and post-exercise as well. In men, we should always remember that there is such a thing as carotid sinus syncope, associated with turning your head quickly or tight collars. You can assess this by sequential pressure to the carotid sinus after you assess for bruit. During close monitoring, put them on telemetry and figure out what the rhythm is. Don't be surprised if it leads to some asystole, so be ready with the medications that you might need, some fluid boluses. We'll go over some medications for bradycardic events in a little while. The mechanism for reflex syncope really is either reduced heart rate, which we call cardioinhibitory, and or a decreased systemic vascular resistance or a vasopressor effect. And it's really important if you can tease out which one of these are the main culprit in somebody's syncope. Sometimes we can do something about it, sometimes we can't. But at least it'll help us figure out how to best help our patients. Orthostatic hypotension is pretty self-explanatory. We won't do on this, but it's due to an inadequate venous return, either from hypovolemia or blood pooling. And now, what causes the hypovolemia or blood pooling is myriad. It can be from things like iatrogenic things like diuretics, hemorrhage, diarrhea, vomiting. And the blood pooling can be caused also, from things that we prescribe, one of many of our vasodilators, but also from primary autonomic or secondary autonomic failure, as can be the case of many of our patients when they have diseases such as Parkinson's, diabetes, and kidney disease. So it's also important to remember that in our patients that are sick with syncope. I just put this slide up as a matter of reference for the diagnostic and treatment algorithm guided by the for circulation. And I'll just give you guys a second to go through that. So going into some of the more concerning types of syncope, which include cardiac syncope. So again, in cardiac syncope, we can break it down to bradycardic, tachycardic, or a grab bag of what we call structural syncope. Now, each one of these is handled a very different way, but many of these things are things that we, specifically us as cardiologists, can't miss in the evaluation of syncope in our patients. That said, we'll go into our second case. A 6-year-old female brought in by ambulance for syncope. She does not recall the events surrounding what happened, and all the collateral we have are from family. She had a sudden transient loss of consciousness that wasn't associated with prodrome, chest pain, palpitations, dyspnea. And it occurred just after she was eating with no post-ictal signs. Her discussion time. She had had 3 events similar to this in the recent past, and seen another hospital with quote-unquote negative workup. When she showed up via EMS to our emergency room, she was found to be bradycardic to 20. Her medical history includes diabetes and hypertension, and her medications are what you see there. And importantly, maybe amlodipine, aspirin, gabapentin, and some Tylenol. A physical exam, when we saw her, her heart rate was 78, her blood pressure was 100/72. She was afebrile, fatting well on 2 liters nasal cannula. That seemed to be there more for comfort than anything. She was ordinary times 3 and no acute distress. Her cardiac exam at the moment had no murmurs, no rubs, no gallops, and her lungs were clear. Abdomen soft, and she had no edema. She was not understanding. Her labs are as such, really a little bit of an anemia, borderline potassium, creatinine of 1.3, troponin, negative, completely undetectable times 2. So nothing striking. This is her EKG. Now with this, I'll take a second and kind of look through this EKG and see what you guys think. But it's important in this EKG. At first glance, somebody might think that this is, ho-hum sinus, but it really is important, especially for patients with syncope, to take a long look at these EKGs, because they can be hiding some scary rhythms. So this patient, in fact, has single heart block with an accelerated junction rhythm. She was admitted to the cardiology service. Initially, she had stable vital signs, as we saw in the emergency room. She had a robust escape rhythm, but overnight she developed worsening bradycardia symptoms associated with worsening hypertension and dizziness. This is the EKG that was obtained during one of their episodes. Now you can see now more clearly the high degree AV block that she's had. She has, multiple P waves not preceded by QRS segments, and then kind of marching. She does have a couple of ectopic beats there, but this is a very concerning EKG. So when it comes to cardiac syncope from bradycardia, there's many possibilities that it can be from. You can't just always think that it's heart block. It could be AV system disease, but it could be sinus node dysfunction as well. Especially in these patients, you have to remember to evaluate for reversible causes. Go over your HCTs as many times. These can be things that can cause bradycardia. We won't go over all those now, but it's going to be really important that as you're assessing these patients, not only are you going to think about how to fix the bradycardia in this moment, but also stop what's happening that's causing the bradycardia in the first place. We have a large armamentarium thing for bradycardia, which can include atropine, dopamine, epinephrine, isoproterenol, transcutaneous, and then transvenous pacing if we need it. I included some of the medication doses that you might need in the hospital. Importantly, just remember that things like isoproterenol, might take a little while to get. They're not usually included on your standard crash card. So atropine, dopamine, and sometimes epinephrine in the formulations that we need are included. So they might be a good go-to while you're waiting for isoproterenol, if in fact it's needed. I won't go over all the steps to put in a transvenous pacemaker. I think that's going to be covered in another session. But what I do want to emphasize with these patients that come in with heart block, severe bradycardia, that are hemodynamically unstable, is number one. Well, remember that you have transcutaneous pacing as unlikely you'll need to use it. You should always remember that it's there. Give them a little bit of medications beforehand for the pain, because it might cause some pain. But if you ever end up needing to use a transvenous pacemaker system, you really want to be familiar with the equipment. Not in the moment that you're having to pull out this pacemaker to put it in the patient, but on your first day, first week of fellowship, go to the cath lab, go to the CCU, figure out where all this equipment is, and get familiar with the sheath introducers, the pacemaker sheaths, the pacemaker itself, and the pacing boxes. Learn how to connect them. Learn how to work the dials and work the buttons, because it's not something that you want to be doing at the bedside when you're putting in the patient. Okay, and we'll go over that if we have time later. So the second big etiology of syncope that can be related to your heart is from tachycardia. Now we're all aware of VT, but it's important to kind of go over it really quickly, as this is definitely something that will come up in your fellowship, and you have to be ready to both identify it and manage it. So just as a matter of definition, ventricular tachycardia is 3 or more complexes originated at the ventricles at more than 100 beats per minute usually. Sustained VT is defined as over 30 seconds of this, either requiring termination by you due to hemodynamic compromise. Non-sustained is what we call them. There are 3 or more complexes, but that terminates spontaneously. Monomorphic is what you would expect, and there's also the polymorphic and bidirectional varieties that are bidirectional is much less common. Again, I won't dwell on this algorithm here. Something that we should be very familiar with. However, and it's easily available in our guidelines. Again, I suggest you go through this. The treatments of sustained monomorphic BP to be able to be armed with that knowledge in case of an emergency. But just to remember that there's underlying things that cause ventricular tachycardia. We always have to work up our patients for ischemia, for structural disease, like hypertrophic cardiomyopathy or just dilated cardiomyopathy. We can't forget about the genetic causes of ventricular tachycardia, such as Brugada and Arlanti T syndromes. And then, unfortunately, there are many times idiopathic ventricular tachycardias, which have several varieties in and of themselves. RVOT with ventricular tachycardia, vesicular tachycardias, and ARVD can all be flavors of idiopathic VTs that we should get at least comfortable thinking about when the more common causes are ruled out. An RVOT VT being defined or identified most commonly by this left bundle branch blocking parent that's with an inferior and posterior directed tachycardia. Generally, these are responsive to adenosine, and for chronic use, you should put them on beta blockers. Vesicular VT can be a little bit more difficult to diagnose because sometimes, or many times, their QRS components aren't as broad and as we're used to. Many times being under 120, with a focus usually from the left ventricle responsive to calcium channel blockers as well. You can see these a lot even in a structurally normal heart. These are classically very sensitive to verapamil, and if they're stable, you can go ahead and try some IV verapamil if you're able to diagnose this. Chronic oral verapamil can be useful if they have recurrent events or as for chronic therapy. ARVD can be difficult to diagnose, but it's caused by fibrofatty replacement of the myocardium. Some tip-offs can be these inverted T waves in V1 through V3, a prolonged terminal activation, and an epsilon wave. We don't have that that's shown here. In these cases, MRI is usually very helpful to diagnose these specific types of idiopathic VTs. That'll show the fibrofatty replacement of the myocardium. Beta blockers are the medication of choice in these patients, and importantly, you have to make sure to advise them to avoid exercise. As the more exercise they do, we've seen that the worse kind of this myopic the disease process gets. 1-2T syndrome, also an important thing to remember when dealing with patients that are coming in with polymorphic ventricular tachycardia. It can be congenital or acquired. It can lead to torsades and polymorphic VT. For the congenital variety, 1TT1 is usually the most common. It usually presents with a resting QTC of over 470 and has these broad-based T waves. Remember, beta blockers are generally recommended, but some are better than others, right? So consider non-selective beta blockers in this sense, and metoprolol might not be your best bet. Things like nadolol or propranolol might be more beneficial. Consider genetic counseling in this patient, and especially if they're clinically diagnosed with long QT. In terms of acquired long QT, well, I'm not going to go over all the medications that can cause this. There are many great websites to be able to do that, but especially if there are patients with long, complex medication histories that come in with syncope, quote unquote syncope, loss of consciousness, found down. It's going to be really important to make sure that they don't have an acquired form of long QT syndrome and torsade. Brugada is going to be an important pattern to know and not miss in your patients that are coming in, especially usually your younger patients that come in with syncope. They're going to have this classic appearance in the precordial lead, V1, V2, with tech, and this is what we would call tech 1 morphology, more than 2 millimeters of ST elevation, leading with a sharp downward deflection into the straight into an inverted T wave here. There's it's important to note that sometimes our plastic placement of our ECGs might not pick this up. So if you're clinically concerned, then it might sometimes it can be brought out by this pattern can be brought out by moving your ECGs up into the second, third, or fourth intercostal spaces, and that really might bring out this pattern. Sodium channel blockers can also bring out the pattern, but that should usually be left to our electrophysiology specialists. We'll do one more case here of Mrs. C, a 43-year-old female presenting with dyspnea and insertion, and an episode of transient loss of consciousness. She had a Syncope episode that occurred after 4 days of dyspnea and nausea. She had abdominal distension and right upper quadrant pain with no palpitations, chest pain prior to this event. It lasted about 1 or 2 minutes, and she had no actual signs afterwards. She had no black or bloody stools, denying chest pain, fevers, chills, unexplained weight loss, and no new medication. Recently, she was diagnosed for recurrent BRCA2 inflammatory breast cancer and surgical history of remote cholecystectomy and hysterectomy her only surgical history. A physical exam, we saw her vital signs, afebrile, but with a heart rate of 123, respiratory rate of 20, and her blood pressure of 108 over 69. Remember, she has a history of hypertension. Her she was studying well in room air. She has acute neuralgia times 4 and no acute distress. With JD was difficult to observe because of her body habitus, but she was clearly tachycardic with a regular F1 F2 was normal and no murmur rupture calyx. She had no wheezes, no crackles. Her abdomen was obese, and her nerve exam was grossly intact. This is her EKG, which I'll take a second to say in general it's a sinus tachycardia. Bedside echo was done on this patient by an astute cardiology fellow, finding a large pericardial effusion. This fellow also was prepared enough to be able to get input variations of the tricuspid and the mitral valve, and did an evaluation of his of the IVC. But importantly, he was able to identify if there was chamber collapse of the right atrium, which is an ominous predictor of an ominous sign of tamponade. He was able to get that in the apical view, but you might be able to see this in other views, including the subcostal as well. Exaggerated inflow variation is another thing that's very important to see in these patients, and it can be another sign of tamponade. Usually we define that as a 25% reduction in inspiratory mitral valve peak E wave velocity, or 40% increase in inspiratory T wave, tricuspid valve peak E wave velocity. And just quickly going through a couple of diagnoses that you really cannot miss is aortic stenosis. So if somebody comes in with syncope with a loud murmur, you definitely want to make sure that you don't miss aortic stenosis. A full echo is going to be necessary to really understand the severity of the stenosis, but it can be very easily picked up even by a first-year cardiology fellow. Just remember that you're going to need to get to the peak velocities and aortic valve VTI of your aortic valve jet, and you need to measure the dense the outer edge of the dense jet. You can find this jet in the apical 5, the 3-chamber, right-sided. Really, you're looking for the highest velocity jet that you can find in any whatever view you can find it in. Remember that you're going to have to get a really careful LVOT diameter assessment. It's going to be very important because this measurement is going to be squared and multiplied. So any error that you make in this measurement is going to be exacerbated in your calculations. Measure this in a parasternal long view during mid-systole, parallel to the aortic valve within half a centimeter to a centimeter of the valve. And the final measurement that you'll have to take for the evaluation of aortic stenosis is going to be your LVOT velocity and VTI, which you're going to be able to measure again from either your apical 5 or apical 3 chamber views using your PW about half a centimeter into the aortic valve. as you can see there. Hypertrophic cardiomyopathy is going to be an important diagnosis to not miss. And I just want to make a quick, I want you to take a quick notice of the difference between an aortic stenosis just here and then this quote unquote dagger-like appearance of this hypertrophic cardiomyopathy that can be, and these two can be confused often. For these patients, it's going to be imperative to maintain them hydrated and rate control when you first meet them. That's going to be all for today. So what we did is we went over some very common diagnoses that you can make very quickly either in the emergency room or your clinic, vasovagal orthostatic reflex syncope. Then we went over some bradycardic case of bradycardic syncope, which you'll now be able to make sure that you assess for heart blocks. You'll have some medications in your armamentarium that you'll be able to use, and you'll be able to hopefully temporize them with a transvenous pacemaker if you need it. And at the end of the presentation, we went over some important tachycardias that we can't miss, and some structural problems that can cause syncope in our patients that we can't miss as well. So I hope that you guys got something out of this today. Congratulations for getting to cardiology fellowship, and it's going to be a fun ride. Thank you so much, and have a good one.
Fantastic, excellent lecture by Dr. Velazquez. Now it's time for a Q&A. We have some questions trickling in as well, and we can get started with that if that's okay with you, Dr. Velazquez. Fantastic. Hi.
Thank you for being here.
All right. Hello. So the first question that came in was in regards to the risk score, and you brought it up. It sounds like this particular person hadn't used it in the past and wanted to know what type of patients you would use the risk score on. Is it all patients? Is it just some patients, etc.?
Yeah, so it depends on the risk scores that the risk calculators that you use, and again, every one of them should you should take care to look at your at the studies to see where in what patients it's validated. It can be different, and depending on what calculator you use, there's not just one. The point that I wanted to make in the presentation is that history and physical is so important in the diagnosis of syncope that a lot of these calculators make a point, and I think it's a really, really important point not to miss, that you really should have as few language barriers as possible when you're assessing them and using these calculators, because otherwise garbage in, garbage out, and you might not be really getting to the bottom of what's going on.
Makes a lot of sense. Thank you.
I think this is actually more of a two-part question. But the first question is, say you get a clinic call and your patient tells you they syncopized. What are sort of the key things you should ask to figure out whether they need to come to the hospital for evaluation versus if this could be worked up outpatient?
Yeah, so those high-risk features that we talked about towards the beginning of the lecture are all going to be really important to ascertain. A lot of them you can't figure out just based on like a phone call, but many of them can be, like if they have a history of MIs, if they have a history of structural heart disease, if they have a family member that has had these issues. A lot of times, there are some characteristics to cardiac syncope that you can see that you can elucidate. Was it all of a sudden? Was it related with injury to your with injury? And a lot of times if you're not sure, then telling them to come in can be prudent.
Fantastic. The next question deals with, you touched on this, the driving restrictions that come with syncope, and that can often be a very sort of frustrating conversation to have with the patient. The patient can get very angry about that and upset. So what is your approach to discussing this with the patient, that you need to either report them to the DMV or that you need to restrict their driving?
Yeah, so if they need, so again, I reiterate the fact it's the rules can be very different depending on what region you're in and kind of what the laws are. But it's always important to like let the patient know that many times they're not permanent. Just while either you're working up the etiology of the syncope, what's going on. Many times they can be reinstated, and really it's just for the safety of that patient and for the population as a whole. The last thing that they would want is to, have this happen again, hurt themselves, hurt other people. Most people, I think, in my experience, can understand that, although it is frustrating, not being able to drive, especially, in our society. It's such an important part of our culture. But I think most people, at least in my experience, once you put it to them in a sense of like, it's not a punishment as much as a protection for you and for your loved ones, they can kind of get on board.
I think this may end up being our last question, but so the question is, what are you mentioned the high-risk features. What are some of the kind of red flags for cardiac causes of syncope if you can't find anything? So I think what this is sort of alluding to is like if someone comes in with exertional syncope, I think that's like the big red flag of needing to look into an arrhythmia of some sort. Like, are there other kind of major red flags that we should be thinking, oh wait, this is cardiac? Assuming the person doesn't have ischemia or like I think congenital, QT syndrome and stuff.
Yeah, and I think so really good question. I think that there's not, that list isn't like a completely exhaustive list of all the things that you should be worried about when somebody comes in, but it is fairly good. And I think it's important to remember, like if the person does come in and they are truly negative for any high risk features that the one that we talked about in the risk calculators, and they have a very good story to support like a vasovagal event or a reflex event, then it's actually, those can be diagnosed on, your physical exam and history, and the risk of them having like, a horrible event, mortality, is actually very, very low. So, in terms of like what the highest risk features are, I think the ones that I listed above are pretty good. Like if they happen with chest pain during exertion, from at rest, and just kind of lose consciousness associated with shortness of breath, palpitations, any of those cardiac features, could anything that kind of would point you towards like a cardiac etiology would be very high risk, and you should definitely have them come in and get further evaluation. And of course, if they have a history of anything like like you alluded to, like an MI, known AS, pulmonary hypertension, anything like this, then you should be very concerned and get them in for evaluation as soon as you can.
Great. Dr. Velazquez, thank you so much for covering a super, super important topic, because I think Megan and I can attest to this, that this is a frequent complaint, but also you see it inpatient, but you get calls about this by patients outpatient, and just the breadth of what it could be, at least, especially from cardiogenic cause, it's pretty broad. So thank you. Just a reminder to everyone, this talk is recorded and it's going to be on the ACC California website. So absolutely, please feel free to refer to it again, because I guarantee you this will come up again and again during fellowship.
Awesome.
Thanks so much, Dr. Velazquez.
Thank you so much for having me. I appreciate it. I will take one second to note that there was a typo in one of my slides about tamponade. So just go ahead and make sure that that's that you guys don't think of it that way. I corrected it in the comments. But thank you so much again. I really appreciate it.
Thank you. Thank you. And thank you all for joining us for today. Our next session is on Wednesday, next week, and that will be Dr. Alicia Romero joining us from Kaiser San Francisco, and she'll be talking about acute coronary syndrome. So it's definitely a very important and practical topic that we all face as general cardiology fellows. Thank you all for joining us, and we hope you have a good day.
Thanks, guys. Yes, Laura, we will have this posted on the website. You will absolutely be able to access the